Thank you, Irene. I have nothing to declare. We are all aware that participants in clinical research must provide informed consent. And in newborns, that means that the parent or the legal guardian must provide consent on behalf of their infant. We know that obtaining prospective consent around the time of birth, studies in the delivery room, is actually very challenging, both practically and ethically. We know that studies that use only antenatal consent may risk some selection bias because typically they exclude the infants that may be at the highest risk of adverse outcome. Mothers who have had poor antenatal care, who present in labour and have a precipitous birth, who are very unwell in the lead up to delivery, or who are unable to be spoken to because of the medication that they're taking. The support trial, I'm sure many of you will know, randomised extremely preterm babies in the delivery room to 2 modes of respiratory support and 2 levels of saturation targeting, and used only antenatal consent. And a secondary analysis of that trial showed that enrolled infants had better outcomes than eligible but unenrolled infants, including more antenatal steroids and better survival. And this raises concerns that antenatal consent risks over-representation of lower-risk infants in studies, and this may limit the generalisability and external validity of study results. So what can we do about this? Well, various governing bodies, including those in Australia, Europe, the US and Canada, allow some forms of a waiver of prospective consent under certain circumstances. Some of those processes later required parental consent to agree to use the data that's been collected and continue trial interventions where that's relevant. But these processes are controversial. They do raise ethical concerns. There is evidence that its use, though, does increase the proportion of eligible infants recruited, and that it enrolls infants with different risk factors, resulting in a more representative sample being recruited. And this may have the potential to actually alter study outcomes, and it may overcome some of the limitations of generalisability. So we aim to evaluate the effects of including deferred consent in a large randomised delivery room trial that compared 2 resuscitation techniques. So this was a secondary analysis of the sustained aeration of infant lungs, the SAIL trial, published earlier this year. And SAIL aimed to determine whether sustained inflations compared with standard positive pressure ventilation at birth reduce the combined outcome of death or BPD without harm in extremely preterm infants. SAIL was a randomised trial that ran for a little over 3 years in 18 NICUs in 9 countries, enrolling babies from 23 to 26 weeks. And planned enrolment was stopped after about 70% recruitment. And SAIL showed us that sustained inflations did not reduce death or BPD at 36 weeks compared with standard treatments. It was stopped because of concern over a higher rate of early death in the intervention group, and it found no important differences in secondary outcomes. But within SAIL, there were different consent processes available. There was both prospective and deferred consent. And to give you an idea of patient flow through the antenatal consent pathway, we can see that eligible mothers were lost at all steps along the process, particularly early on with those that were unable to be approached because they burst. And the result was that babies from just 21% of eligible mothers were actually assessed for eligibility at birth. So in our secondary evaluation, we looked at the 18 recruiting centres, 12 of which used only prospective antenatal consent, and 6 sites in 4 different continents allowed deferred consent, and 2 of those were only using deferred consent. And we chose to compare the 6 centres where deferred consent was available versus the 12 centres where it was not. And we compared the proportions of eligible infants that were recruited, their baseline characteristics, and some of the SAIL outcomes, including the primary outcome and its individual components, and some secondary outcomes. So when we look at the inclusion criteria, for the centres that used antenatal consent, under half of the eligible infants were ultimately recruited into the trial, whereas the centres that had deferred consent available recruited almost 3/4 of those infants ultimately into the trial, a statistically significant absolute difference of 31%. When we look at the demographics of the mothers, we see that where deferred consent was available, mothers were a little older, they were more likely to be Caucasian, they were less likely to have completed a course of antenatal steroids, and there was a borderline difference in the amount of antibiotics they received. Again, the deferred consent available babies had less chorioamnionitis and were more likely to have had a vaginal birth. There were less caesareans. When we look at the babies, in the centres where deferred consent was available, the babies were more likely to be male. They were a little heavier and less likely to be growth restricted. They were also less likely to be intubated in the delivery room. When we look at the primary outcome, at the sites where deferred consent was available, the infants actually had an 8% higher rate of death or BPD compared with the centres using antenatal consent, although this did not reach statistical significance. Both the components of that also went in the same direction. When we look at the outcome by the randomisation group, at the centres using only antenatal consent, there was just 1% difference in the primary outcome compared with nearly 10% difference in the centres where deferred consent was being used. Last, if we look at the secondary outcomes, the babies enrolled in centres using deferred consent were more likely to have intraventricular hemorrhage and more likely to have necrotising enterocolitis, but interestingly they had lower rates of retinopathy. So what does this mean? So I think the findings confirm what previous studies have shown, that an increased proportion of eligible infants were enrolled when deferred consent was available. And apart from maybe getting to your desired target enrolment number quicker, does this matter? Well, it does matter if the babies that you now include are different from the babies that you would have included if you hadn't used it. And it matters because if the intervention you're testing was found to be beneficial or harmful, that intervention will then go on to potentially be applied to or withheld from the whole population, not just those it was tested on. And extrapolation of results to the wider population may not have the expected effects. We saw that we had higher rates of IVH and necrotising enterocolitis in the deferred consent group, and it was interesting to note that there was a wide difference in death and BPD in that group as well. It was wider than actually the SAIL outcome. This is the SAIL primary outcome data. We saw that by the randomisation groups there was a 4.7% risk difference in death or BPD, whereas if we don't look at that and we look at by deferred consent availability, we see a wider difference. But perhaps more interesting is the difference looking at the primary outcome by consent type. We see that there's a much larger difference when deferred consent was available, and I guess that makes us question what the SAIL trial might have shown if all of the centres had only used antenatal consent, or if all the centres had had deferred consent available. And I guess it highlights how different consent modes have the potential to affect trial outcomes, and makes us question how we should recruit to similar trials in the future. Should waived or deferred consent be more widely considered for delivery room trials? And if it was, would it be acceptable to clinicians, to researchers, to ethical review boards, and to the parents and the public? If we did use it more widely, we'd have to consider the difference in requirements and the difference in acceptability of this kind of consent across different countries around the world. And perhaps we need to consider whether other more appropriate consent modes, such as opt-out consent, might be appropriate, and if so, what impact they might have on enrolment and outcome. So this analysis was done on prospectively collected data from a large cohort of extremely preterm infants, but it was a secondary analysis of randomisation data. It was potentially underpowered to look for outcome difference, and we chose to analyse by availability of deferred consent rather than by individual consent processes. And you could argue that perhaps doing it by individual consent processes may have shown differences, but we don't really assume that deferred consent would ever be the sole method of recruitment into trials, and that's why we chose to do the analysis by the effect of including deferred consent. And also we may need to consider the impact of regional differences on these outcomes. So in conclusion, within SAIL, the inclusion of deferred consent resulted in a higher proportion of eligible infants recruited, resulted in baseline differences including less exposure to antenatal corticosteroids. It did result in some outcome differences, including higher risk of NEC and IVH and less retinopathy. And it also resulted potentially in a larger effect of the SAIL intervention in one group. I think we need to remember that a study sample recruited using only antenatal consent may select a subpopulation that is not representative of the whole population to whom the results of the trial will be applied. And we need to be cognizant of that in our interpretation of this kind of research. I'd just like to acknowledge all of the SAIL trial investigators, in particular Sarah Ratcliffe, for her statistical support. Thank you.